Hello and welcome, and thank you for taking the time to review this presentation and to listen to it. It's about using topical anaesthetics for anaesthesia of the skin. My name is Roger Bloxham and I'll be taking you through the contents of this presentation. As a disclosure, I'm the Managing Director of Ferndale Pharmaceuticals Limited and our Aesthetics Division, Aestheticare. We are the marketing authorization holder and the manufacturing supplier of LMX4 lidocaine 4% cream. As we go through this presentation, what we're going to look at is the anatomy and physiology of the skin and how that relates to the pain sensation we get from sensations and procedures on the skin. We'll look at the mode of action of the topical anesthetics, how those local anesthetics work. We will concentrate in this presentation on MHRA approved topical anaesthetics, and we'll go through those that are available, look at their indications and how they should be used. We'll also spend a little bit of time looking at the potential side effects of topical anaesthetics, and we'll spend some time looking at how they're formulated in the different delivery mechanisms. And this is quite key because putting an active local anaesthetic ingredient in a cream or an ointment is not going to necessarily enable the delivery of the local anaesthetic to the site that it's needed at, which we'll look at, which will be the nerve ending. And finally, we'll spend a little bit of time looking at the clinical practice and how these topical anaesthetics can be used. The anatomy and physiology of the skin is important in how pain is received, pain stimuli are received, and also how topical anaesthetics work. So if we think about the skin as the layers, the two primary layers of the epidermis and the dermis, the epidermis is the outer layer. The top part of that is the stratum corneum. This is a dead cell layer made up of corneocytes, which are held together by small linkages called corneodesmosomes and skin lipids, which sort of act as a cement almost between these cells. Below that, we have the living part of the epidermis, although all parts of the epidermis are avascular. And the primary cell here is the keratinocyte, and also there are melanocytes which help produce the melanin, which gives the skin the pigmentation. These keratinocytes are eventually converted into the corneocytes, and they move up through the epidermal layers, and eventually they're sloughed off at the surface. So we've got this continual cycle. The epidermis is the site where we do find nerve endings. But it's at the lower level of the epidermis, in the granular cell level. So that's the point at which we can first feel pain, because there's a nerve ending which can receive a stimuli that is transferred into pain. The rest of the nerve endings in the skin, which is our sort of primary sensation of external pain, is in the dermis, and that's at the point of the papillary dermis, which is in the closest part to the epidermis, and in the lower parts in the reticular dermis. So when we think about applying a local anaesthetic to the skin in the form of a topical anaesthetic, i.e. a local anaesthetic in a cream, ointment, gel, maybe even a liquid at the surface of the skin, firstly, it's got to get through that outer layer. It's got to get through the stratum corneum, and it needs to get at least as far as the granular layer to have any pain reduction effect. If we are doing procedures into the dermis, then obviously that anaesthetic has got to get through all of the epidermis and start to penetrate into the dermis to be available at that point for the nerve endings that are there. So that gives us a sort of limitation in a sense in terms of how deep can we go, and also it's got to transfer. So that starts to have an effect on speed of onset. So the formulation of the anaesthetic in terms of its topical vehicle, cream, ointment, gel, liquid, how is it actually formulated that will allow it to transfer itself from the surface through to the point of the nerve endings. And we'll talk about this in a little more detail as we go through the presentation. So we're going to spend the next couple of slides just looking at how pain actually is initiated in the skin and how it is received into the brain as a pain signal, which we go, ouch. It is quite important we just do this over these few slides because it's fundamental to how local anaesthetics work. So effectively, pain is when the brain receives a message in the form of an electrical signal that's received, and it's transmitted to the brain by the central nervous system. It gets to the central nervous system from the peripheral nervous system, and it all starts by the stimulation of a free nerve ending within the skin tissue. We have many of these nerve endings within the skin tissue. They're most prevalent in our extremities, hands, lips, face, neck, etc. All areas where we're doing cosmetic procedures, and therefore that's why we often need some form of pain control. When we think of the pain receptors, they are actually just the free nerve endings. They are actually just neurons which make up the nervous system, both peripheral and central nervous system. It's just that they don't have a protective outer sheath, myelin sheath. And that myelin sheath normally actually provides a form of insulation, protection of the neuron, and that allows electrical signals to be transmitted along them more quickly. In the case of the nerve ending, then actually it makes them more susceptible to the reception of stimuli. So to look at how local anaesthetics and therefore topical anaesthetics in their most basic form, we have to just look at a little bit detail how a stimuli in the skin can be transduced into a pain stimulus, and it does that by taking the physical trauma. The physical trauma is in many cases will form some form of acute inflammation, so you then get a chemical and chemotaxis activity taking place in the skin. All of those then have to transfer into an electrical stimulus to actually transfer along the peripheral nervous system up through the central nervous system into the brain, and so the brain can go, that hurts. This happens at the nerve ending by the electrical potential of the nerve membrane changing. So within the neuron, there's a slightly negative charge, and outside the neuron there's a slightly positive charge. This is managed by a selectively permeable sections of the membrane changing the way they behave. These sections are known as sodium channels, and the sodium channels have what's called a voltage gate. So when this stimuli happens within the skin, actually these voltage gates go from the sodium channels go from being at rest to being open, and by being open they become selectively permeable. What they become selectively permeable to is sodium ions. So at rest and in normal state, when there is no pain stimuli, you will normally find around about 10 times more sodium ions outside of the neuron than you would find inside the neuron. And within the neuron, there is around about 10 times more potassium ions than you would find outside of the neuron. And this gives you an electrical voltage difference between the outside and the inside. When the sodium channels open, then sodium ions flow into the neuron. This has the effect of changing the inside of the neuron to a slightly positive charge. Once it achieves a level of equilibrium, then the sodium channels can close. It's this change in electrical signal that actually this electrical potential that creates electrical signal that then is transferred down from the free nerve ending down the peripheral nervous system to the central nervous system and eventually to the brain. So how does a topical anaesthetic work? Well, it works by actually blocking those sodium channels. So in its ionic form, it actually binds with those sodium channels, and therefore it stops the flow of the sodium ion from the outside of the neuron to the inside of the neuron. And therefore, although the stimuli is there, the nerve ending doesn't get triggered or fired, as is often said, and the electrical stimuli doesn't flow all the way through to the brain. When we think of that membrane that has the sodium channel in, the membrane is made up of phospholipids, so it's a lipid membrane. And when we think of the topical anaesthetic, typically they will be lipophilic. And how lipophilic the topical anaesthetic is often going to dictate how effective it is, and also how long the duration. So the more it is attracted to that lipid membrane, the more it can block the channel, then the greater the effect and the longer the duration. So to summarize, local anaesthetics in the form of topical anaesthetics, a topical cream, ointment, gel that contains a local anaesthetic, work by stabilizing these neuronal membranes. So the membranes at the nerve ending, which is an unmyelinated part of the neuron. That stops the movement of ions when we get a pain stimuli. Particularly, it's the sodium ion that moves in and that creates a change in electrical potential within the neuron, which causes an electrical stimuli to be transmitted all the way through to the brain. By stopping that activity at the surface of the membrane, we stop that impulse. And that's how local anaesthetics work. So the birth of local anaesthetics actually started in the late 1800s with the introduction of cocaine, and it was used on things like corneal abrasions and corneal pain. But there's problems, and dependency is obviously one, and the first ester forms of local anaesthetics were developed and started to be being used in the early 1900s, and in the 1940s the first amide local anaesthetic, lidocaine, was developed and introduced. The difference of whether it's an amide or ester is quite fundamental, and we'll go on to spend a little bit of time just looking at that. And it has a big impact on the stability of the product. When we start to look at it, its use on the skin, how it's most likely to penetrate, and its onset, and also its duration. A key thing to consider within this is potential to cause allergic reactions. When it's used as an injection, then systemic allergic reactions. When we use it on the skin, we're often concerned about skin sensitivity reactions and skin reactions, allergic reactions, and it also has an effect on its systemic toxicity. When we look at the chemistry of the local anaesthetics, they're very similar as we look across them. So they're all characterized by an aromatic portion, and that's normally an unsaturated benzene ring. There is then an intermediate chain, which is a hydrocarbon, and then they connect the other end. There's a hydrophilic group, which is normally a tertiary amine or a protein acceptor. How the hydrocarbon chain is connected to the benzene ring is what differentiates the classification. So they're either connected by an amide linkage, and therefore they're classified as amide local anaesthetics, or they're connected through an ester and linkage, and therefore they're known as esters. When we think of the two groups, then when we think of amides, then these are the most well-known anaesthetics, local anaesthetics probably. The lidocaine is the classic, also includes prilocaine. These are moderately lipophilic, that gives them a reasonable onset of efficacy and also a medium duration of effect, and they are very, very well tolerated. When we think of the esters, then this is tetracaine, also procaine, benzocaine. These are generally more lipophilic than the amide, and that gives them a greater duration typically. However, they are more sensitizing than the amides, and they have a greater propensity to cause allergic reactions. They are also more potent vasodilators. For this reason, the amides have become the predominant local anesthetic that's used by injection. So when it's injected directly into tissue and close to vascular supply. So we will now move to the local anaesthetics available as topical anaesthetics in the United Kingdom. These are all MHRA approved medicines, and we were only focusing this presentation on MHRA approved medicines. The reason for doing that is that there is a selection of products available to practitioners that when we think about what we're trying to achieve, surface anesthesia, so cutaneous anesthesia. If we have more invasive procedures or deeper procedures, as most of those procedures will or should be being carried out by medical practitioners, there is access to injectable local anesthetics. And also all of these products have a known efficacy and safety profile, and they have all been assessed by the agency to provide reasonable and acceptable balances of efficacy, clinical efficacy, with an acceptable safety profile. If we start to move outside of this area into unlicensed medicines, we don't know that, and for that reason this presentation won't stray outside of approved medicines. All of the medicines are that we feature here, and you can see the main ones that we're going to talk about are classified as pharmacy medicines. That means they are available without a prescription, but if retailed to the general public, then they can only be retailed through a pharmacy, and they need to be kept behind the counter within a pharmacy. When you're acquiring them, buying them for use in your clinical practice, then they should only be acquired through a company with a pharmaceutical wholesale dealer's license. That's approved by the MHRA with an appropriate supply chain mechanism, or from a licensed pharmacy. And again, that's one of the key reasons we will focus only on MHRA approved medicines in this section, in that these are all available and generally widely available, both to members of the public or to the clinics, and there are companies and pharmacies supplying the medical aesthetic practitioners who have a ready supply of these. So we'll start to work our way through the topical anaesthetics available that are approved by the MHRA. The first one we'll cover is Emla, and is known as Emla Cream 5%. 5% represents the total amounts of topical anaesthetic, and it is a combination of lidocaine 2.5% and prilocaine 2.5%. The product was available from AstraZeneca, as many of you may know, historically, but it was acquired by Aspen Pharma, I believe it was last year, and as they acquired the local anaesthetic portfolio from AstraZeneca. Emla Cream is probably the best known topical anaesthetic, both within the UK and around the world. It was the first topical anaesthetic that really took local anaesthetics and found a way to get them to penetrate effectively through the surface layers of the skin to give a reasonable onset and a good level of analgesia, pain control within the skin, and allow skin procedures to take place. And it did it in a way that built up sufficient amount of clinical data and safety data to enable the regulatory authorities, both in the UK and with the FDA and around the world, to give approvals. As it's been the longest available, it's got a wealth of data available, and for that reason as well, it's probably no surprise it's got the broadest range of therapeutic indications. As I mentioned, it is a combination, so it uses two amide local anaesthetics, lidocaine at 2.5% per weight of weight per weight, so weight of active against the weight of the cream, and prilocaine at 2.5% as well. So for every gram of cream, there was 25 milligrams of lidocaine and there's 25 milligrams of prilocaine. It is a white soft cream and it is indicated for topical anaesthesia of the skin related to needle insertion. So probably its most widest use is in terms of just number of procedures is venipuncture and venous cannulation, and for superficial surgical procedures on the skin, and it is approved in both adults and in children. It is also indicated for topical anaesthesia of genital mucosa, and it is the only product that has that approval. And that's to superficial surgical procedures, and that's for adolescents and adults aged 12 and above. And also it is the only topical anaesthetic to have an indication for use in leg ulcers, and it's used in the debridement of leg ulcers, but that is only within adults, but that indication is predominantly in the adult population anyway. So let's look at the dosages and application times for EMLA. So for minor procedures such as needle insertion, or a cannula, for example, going into the often into the back of the hand, or for a local surgical treatment of localized lesions, then you would apply 2 grams to, normally if it's for a needle insertion to a small area, say of about 2.5 centimeters by 2.5 centimeters. If it was a larger area, then of say 10 centimeters squared, then you could go up to around about 1.5 grams, so just less than a half a tube for an area of 10 centimeters squared. Now the minimum application time for an onset of action is an hour, and it can be left in situ for up to 5 hours. So for, say, in a hospital setting where people are waiting for a cannula prior to, say, anaesthesia for a day procedure, etc., that flexibility of putting the product on and being able to wait for up to 5 hours is beneficial. The fact that if you need to do a procedure within an hour of application, obviously that's a problem, because you need to leave on for a minimum of 1 hour. For dermal procedures on larger areas of skin, and the example that's given here was laser hair removal, probably from when laser hair removal was more painful, then the recommended maximum dose is 60 grams over a maximum area of 600 centimeters squared. So that'd be 1 gram per 10 centimeters square area. Again, the minimum application time is 1 hour, and it can be left in situ for up to 5 hours. For dermal procedures on larger areas, but for more invasive procedures, and it clearly states here in a hospital clinical setting, such as split skin grafting, then application will be for up to 2 grams on an area of 10 centimeters squared, but a minimum of 2 hours application time will be required. And as we mentioned in the previous slides, EMLA is the only topical anaesthetic in the UK that's approved for use on genitalia. So for the skin of male genitalia, and this is for anaesthesia prior to injection of local anaesthetics, which in itself can be painful, then you'd apply around about 1 gram per 10 centimeters squared for 15 minutes. So there's a much faster onset through the thinner skin and the mucosal membrane there. And for the skin of female genital organs, then actually you can apply more, so you go up to 2 grams per 10 centimeters squared, and that would need to be in situ for 60 minutes. So now let's take a look at how EMLA cream is applied. All of this information is taken from the summary of product characteristics for the product. This is the approved documentation from the MHRA. This can be viewed from public sources. Often the summary of product characteristics is abbreviated as the SPC. But there are more details contained there within this document, including contraindications, etc. So, and these are publicly accessible. It will be applied as a thick layer. and would be applied under occlusive dressing. The only time when EMLA isn't applied under an occlusive dressing is on genital mucosa, and also when it's used for the debridement of leg ulcers. When we get to talk about how the delivery mechanisms of these creams and how the local anaesthetics penetrate through the skin work, how that mechanism works, then we'll see that occlusion is quite important for a product like EMLA. The next product we'll look at is LMX4. LMX4 is a lidocaine 4% cream. So for every gram of cream, there's 4 milligrams of lidocaine contained within it. I won't go into the delivery mechanisms of the lidocaine, i.e. how the lidocaine penetrates through the skin, just as I didn't do that with EMLA. We're going to look at that in the next section. It's a white to off-white yellowish cream. It is available in the United States since around the year 2000. Originally, it was available under the brand name Elamax, and the brand name changed to LMX4 in the mid-2000s. It was approved around 2008 in the UK, and then became available not too long after that. It is also available in other markets. So in Canada, it's available under the brand name Maxilene. It's fairly recently been approved across Europe, and so it is in the process of being launched and rolled out across Europe. It's sold as LMX4 in places like Australia, and is marketed in Brazil as the brand Dermamax. So it is available in a number of major markets around the world. In terms of its indications in the UK and similarly across Europe, it's for use before needle procedures such as venous cannulation and venipuncture, and is approved also for usage on larger surface areas of the skin prior to painful topical treatment. So let's look at the dosage and application times for LMX4. Firstly, we'll look at venous cannulation or venipuncture. It is approved for use in children and adults, and that includes the elderly as well, although the majority of cannulation and venipuncture procedures take place in children. In terms of the application, we would normally apply around about half a tube, so that's 1 gram to 2.5 grams of the cream onto the skin to cover an area of around 2.5 centimeters to 2.5 centimeters, and that's at the site of the needle insertion. For children under 1 year of age, then no more than a gram of cream should be applied to the procedure site. Normally this would be occluded to stop fingers being put into the cream, etc., and it being disturbed, although there are clinical studies that indicate that occlusion is not required for the onset of efficacy. The minimum application time is 30 minutes, but the product can be left on for up to 5 hours. So one has the flexibility of putting the product on, the site being ready for the procedure after 30 minutes. But if there is an undue delay or something happens, then the product can be left in situ under a dressing until it is required. The maximum application time does vary for age groups. So if the child is 1 month to 3 months, then the maximum application time shouldn't exceed 60 minutes. And for 3 months to 12 months, it shouldn't exceed 4 hours. For infants of 12 months or above, more elderly children, adolescents and adults, it can be left in situ for 5 hours. As we mentioned before, LMX4 is approved for applications to larger surface areas of the skin, that being intact skin. The majority of the approvals apart from EMLA, where there's use on genitalia and debridement of leg ulcers, the approvals relate to application to intact skin. The approval is for use in adults, including the elderly, but it is not approved for children, patients below 18 years of age, for this particular usage. Of course, we discussed earlier, it's approved for needle procedures, venipuncture, cannulation, down to 1 month of age, that being smaller areas. The product would be applied around 1.5 grams to 2 grams of LMX4 per skin area of 10 centimeters squared, and it can be applied up to a maximum area of 900 centimeters squared. The onset of efficacy is from 30 minutes, and there is clinical evidence that the onset can increase between 30 to 60 minutes. The typical areas that we'll be applying this to mean that most body areas that painful treatments will be applied to the skin can be covered. So as the examples are given in the SPC, then we could be covering 200 centimeters square, so typically you'd be using around 30 milligrams for that area, so that could be up to a face, covering an area such as the face. 300 centimeters squared would be covering an arm, and one could be using between 1 and 2 tubes, 30-gram tubes for that, or actually you could be using it on the whole of a back or a torso. And in which case we could be using around from about 135 grams of product upwards. It will be applied at a uniform thickness across the area, and we try and leave that product undisturbed. It doesn't have to be occluded for efficacy, but obviously we do need a good application of the product across the area for the dosage of the active ingredient to be applied. Prior to starting the procedure, as with all the topical anaesthetics, it should be removed and the area prepared in the normal manner before we're starting that procedure. This information and the other information for the topical anaesthetics that I'm referencing are taken from their summary of product characteristics, shortened to SPCs. All of the information for EMLA cream and LMX4 can be found on the central website called medicines.org.uk. I've referenced that on the bottom of the pages of the previous slides, both for EMLA and LMX4. And this is the electric medicines compendium. It's usual for pharmaceuticals to be their SPCs and their patient information leaflets to be contained on this site, but not all medicines are. And you'll see as we move on to the other two products, I've had to find other reference sites on the internet that could be accessed so that you could find their summary of product characteristics in full. Next, we'll move to the most recent addition to the armoury of topical anaesthetics in the UK, Pliagilis, and this is from Galderma. Pliagilis contains two topical anaesthetics, lidocaine and tetracaine, so an amide and an ester. So and it's the only one to contain of the approved medicines to have a combination of the two different types. It's 7% lidocaine and 7% tetracaine. So for every gram of product, there is 7 milligrams of lidocaine and 7 milligrams of tetracaine. It's a cream. It's white to off-white, viscous, and it's indicated for use in adults to produce dermal anesthesia of intact skin prior to dermatological procedures. The summary of product characteristics, also known as the SPC, isn't available or wasn't referenceable at the time of writing of this presentation on the Electric Medicines Compendium, but it can be found by digging around on the MHRA government, so the mhra.gov.uk website. Pliagilis is indicated for use in adults and the elderly. It's not approved for use in children. The dosage, application, time and method administration in the SPC is combined into one section, a little like it was within the LMX4 SPC, and we'll just review that here. So when we look at dermatological procedures such as pulsed laser therapy, hair removal where that's painful, resurfacing, dermal fillers, etc., then It would be applied at a thickness of about 1 millimeter and left for 30 minutes. So the time of onset will be from 30 minutes. And you're applying around about similar amounts when we look to the other products of about 1.3 grams to 10 centimeters squared. So not too dissimilar. The interesting thing about Pliagilis is that it forms a kind of peel, a film rather, over the surface of the skin, which would then be peeled off and removed in that manner. And so we can see in the SPC that it references a peel. That's because it's a film forming formulation. For more invasive or more painful and deeper procedures such as tattoo removal and leg vein ablation, then it would be applied in the same manner, same amount, but would need to be left for 60 minutes. And then it would be removed from the skin again prior to the procedure. And the final product that we'll review in this section is called Ametop gel. As the name suggests, it is a gel, so it differs from the other products which we've reviewed, which were all creams. It contains one single active, tetracaine. If we recall from our previous discussions, tetracaine is an ester topical or local anaesthetic. It's in a concentration of 4%, so for every gram of gel there'll be 4 milligrams of tetracaine. Unlike the other products, the pack size that Ametop is available is limited. So Emla and LMX4 cream are available in 5 gram tubes and 30 gram tubes, and Pliagilis was available in 15 grams and 30 gram tubes. Ametop is only available in 1.5 gram tubes. Its indications are also more limited in that it is for the local anaesthesia of the skin prior to venipuncture and venous cannulation. When it's being used, you'd apply normally the contents of a tube to the area to be where the needle insertion is going to take place, and it would always be occluded. In the case of children under 5 years of age, then only one tube should be used at a time. So therefore the tube should be split, and often and routinely in children, 2 potential cannulation sites would be prepared in one go, in case access to one of the areas proved difficult. So in those cases, a 1.5 gram tube needs to be split over 2 areas. Its speed of onset is comparatively good to the others, so it's comparable. It's faster than Emla, so its application time is 30 minutes for venipuncture and 45 minutes for a venous cannulation. So it's comparable to LMX4, which is 30 minutes for venipuncture and cannulation, between 30 and 60 minutes for larger areas of the skin. This product is not approved, so this Ametop is not approved for larger areas of the skin. Again, the information can be found in the SPC. This isn't available on the electronic medicines compendium, but if you dig around, it is available from the MHRA site, and is also available on the Smith & Nephew website if you look carefully as well. So let's have a look at the potential side effects from topical anaesthetics. Rather than go through these individually for each of the topical anaesthetics we've reviewed, I've grouped these together because many of the effects are very similar. The first group of effects that we'll look at are the cardiac effects. Now, for cardiac effects to be seen as a result of use of topical anaesthetics, then we need to have had a significant amount of systemic absorption of the local anaesthetic. This would be very unusual. Firstly, we need to think about how it's applied. It's applied topically. The product has to absorb through the surface layers of the skin, as we've discussed. Its penetration is within the epidermis, the dermis, and to an extent into the hypodermis. These areas are not highly vascular, and the amounts of products of the local anaesthetic we're applying and is being absorbed is limited. So it is unusual for us to see systemic effects. One of the reasons that we've concentrated our review on the MHRA approved local anaesthetics is that the safety review has taken place. And in terms of systemic effects, then at the dosages applied, and for the durations they applied to that the product is applied for, then the levels of systemic absorption are known to be very low, and the incidence of cardiac effects are very low, rare, and I mean will be classed as rare or non-existent. However, we do need to be aware of them, and there may be occasions where this can happen. So the effects that we could see are the slowing down of the heart, bradycardia, we could see irregular heartbeats, arrhythmias, and we could see a drop in blood pressure. And there's the potential for collapse of the patient and potential cardiac arrest. Now, again, as I mentioned, the dosages would have to be very high. For example, for lidocaine to have observable systemic effects, then we need to get a concentration of greater than or equal to 1 microgram per mil of blood. For those results to be toxic, then it would need to be greater than 5 micrograms per mil of blood. In all the studies then that have been observed where the systemic levels of lidocaine and metabolites have been observed with both EMLA, LMX4, and with the other products of their forms of local anaesthetics in the topical anaesthetic formulations, then we don't get to these levels. And that's why it's important we try and stay within the guidelines of the dosages and the recommended application areas. Movement outside of this means we're moving into areas where we don't know what the absorption levels are, and therefore it's difficult to predict, or becomes more difficult to predict what the systemic effects are. When we review these systemic effects with respect to the cardiac effects, we also need to think back to the mode of action of the local anaesthetics. If you recall, we talked about them blocking sodium channels. In this case, it's fantastic because it's in the unmyelinated part of the motor neuron, i.e. the pain receptor. By blocking the flow of sodium ions into the neuron, we were stopping the transmission of what was a painful stimuli into an electrical current that would pass along the peripheral and central nervous system, and therefore stop its perception being as pain. When we look at the cardiac tissues and cardiac muscles, there are also sodium channels, and the effective local anaesthetics is not selective to sodium channels only on the nervous tissues, onto neurons. It can have effect on other tissues. So in that way, it will affect the sodium channels if it gets into high systemic levels around the cardiac tissue, cardiac muscles, and it can start to have these effects. Again, I would stress that we need high systemic levels of the local anaesthetic for that to occur. That very rarely happens with topically applied local anaesthetics, and particularly if we use products that are approved and licensed by the MHRA and we apply them within the approved dosage range, or where at least there is clinical data and systemic and pharmacokinetic data that has been performed and is in the literature that can show that there's a good level of a good safety profile for its use. The other side effect or safety profile of the topical anaesthetics we need to assess are its vascular effects. And the reason, particularly for dermatological procedures, that this is relevant is because the vascular response to the topically applied local anaesthetic can change the appearance of the skin due to these vascular responses. And when dermatological procedures are being carried out, this can be of significant relevance. The two effects that we primarily need to think about from a vascular effect in terms of the procedures is vasoconstriction. that tends to cause a blanching, a whitening of the skin. Now, most of the local anaesthetics have some vasodilatory effect. Interestingly, prilocaine of the amides has a reasonably significant blanching effect, and therefore we can get a whitening of the skin. Now, there may be some procedures, particularly in laser procedures for vascular problems, where we don't want to see that, or it may be a disadvantage to the clinician if that occurred. So that would be a factor in using the topical anaesthetics with the local anaesthetic prilocaine in, and that would be EMLA or any generic variant of EMLA. The second vascular effect that we need to think about is vasodilation, and that manifests itself in redness or erythema. The ester anaesthetic, local anaesthetics, are particularly prone to causing this issue of erythema due to vasodilation. So tetracaine is known to be have a reasonable level of erythema, cause a reasonable level of erythema. And whilst this can happen with lidocaine, so it can happen, then its incidence is less than would happen with tetracaine or the other ester-based local anaesthetics. Now, again, this just needs to be considered when one looks at products which contain ester-based and local anaesthetics, such as tetracaine, in that the level of vascularity that can be seen, the level of redness, and does that interfere with the procedure that's going to be taking place. And that's just a factor that needs to be considered when choosing the local anaesthetic. The final vascular effect that needs to be considered is methemoglobinemia. Now, this is, compared to the other two, is very rare. This is the condition where methemoglobin can be formed due to the use of the local anaesthetic, and prilocaine is the local anaesthetic this is most usually associated to. The problem once this occurs is that actually methemoglobin does not hold the oxygen. Oxygen doesn't bind to it in the same way that hemoglobin would do, and so therefore it can reduce the availability of oxygen to the tissues. It is a rare condition that this would for this to happen, and large doses of the prilocaine are required. It has been raised in the past as a concern, particularly in use with children, but it is not a widespread concern or issue and wouldn't normally be associated with a high risk when considered in dermatological uses. So to finish this section around its potential side effects of topical anaesthetics, and more appropriately, I think, whereas it is topical, we're looking at its effect on the skin and the skin reactions to it. I just want to conclude by spending a little time just talking about the sensitivity to the topical anaesthetics. As I mentioned in my disclosure at the beginning, I am from Ferndale Pharmaceuticals, so we do have an interest in this area. We have a topical anaesthetic as part of our medicines portfolio. And we recently commissioned a review of the literature, an independent review of the literature, to look at sensitivity to topical anaesthetics. And the review concluded that, and this data is on file, so it wasn't for publication, but it was an academic process that we went through. The review showed that there were 111 articles since about 1970. And basically, we concluded from this, or the authors concluded, that as we know, there are the two groups, amides and esters. there can be hypersensitivity reactions and they can be delayed or immediate sensitivity. And the most prevalent form of that, and we talked about vascular effects and sort of erythema, which would be short term. Here we're talking more around about can it actually, with regular and repeated use, turn into more factors such as contact dermatitis. Interestingly, and this is this was believed, and it's borne by all the literature reviews, is that there is actually no cross reactivity between both the ester and the amide groups. So, which is very interesting, and also very interesting that is within those groups there necessarily isn't cross reactivity or sensitivity. So if in your clinical experience somebody is becomes sensitive or is sensitive to a local anaesthetic applied topically, by changing to another topical anaesthetic, be it within the same group, another amide, or within the same group, be it an ester, you necessarily won't see the same reaction. So by moving from one group to another, you won't necessarily see a sensitization reaction, and that also exists within the group. So that's good and interesting data. The data does support the fact that that whilst we see them for both amides and esters, and within that it does need to be recognised that amide local anaesthetics when applied topically are used much more prevalently and much more prevalently worldwide than the ester anaesthetics such as benzocaine and tetracaine are used. But the sensitivity can be seen to both of them, but there is a prevalence for more allergic sensitization reactions to the ester local anaesthetics when applied topically. And it's thought that some of this is down to the metabolized byproducts of the actual original local anaesthetic. So I thought that was interesting information, and I just wanted to share that with you. This is probably most relevant rather than the short-term vasodilation erythema that can be seen. But if a patient is getting has repeat treatments and has repeat applications of a local anaesthetic, there is a potential every now and again that you can see a sensitization build up in that patient and then start to occur as a delayed response reaction. That is more likely to be seen with an ester-based local anaesthetic when applied topically, but actually moving to an amide or even moving to another ester-based local anaesthetic could remove the problem. Of course, there aren't that many. The only products that contain ester-based local anaesthetics topically are Amitop, which is only indicated for venipuncture and cannulation needle procedures and are on the small tubes, or Pliagilis. So we're now going to look at how the local anaesthetic in the topical product is actually delivered through to the site of the nerve endings and the source of the pain. So this is one of the interesting bits, and where we can see some differences between the products. The challenges for all of those products is how do we get the local anaesthetic firstly out of the vehicle, i.e. the cream or the gel, and how do we get it through the stratum corneum and into the epidermis and into the dermis where the pain receptors are. Traditionally, local anaesthetics have been applied to tissue where we were trying to numb and reduce the pain by injection. So it was being put directly at the site of the potential pain. When we were applying it topically to the skin, okay, it was on the skin and we were trying to numb and reduce the level of pain reception in the skin, but we were applying it to the surface of the skin. We weren't putting it directly to the lower levels of the epidermis, the dermis, or the hypodermis. So we had a challenge. How does that local anaesthetic, firstly, as we were saying before, get out of the cream or the gel vehicle that it's contained in? And then how does it get through to the site of the pain receptors? Now, when we apply a product topically, we normally have three ways to get through the stratum corneum. There's the shunt pathway, so that's where it gets through the hair follicle and the sweat gland, and that's quite a useful mechanism for larger molecules that we want to get through. Of course, whilst that can give us direct access through into the dermis, it's a small part, it's a very small part of the surface area of the skin. The other route is the intracellular route. That's where the product can penetrate through the intercellular lipid spaces between the cornea sites within the stratum corneum. And then the other route is that it actually diffuses through the cornea sites. One of the other key factors that has to be considered here is the vehicle, i.e. what is the active ingredient contained in. And when we say vehicle, we mean the topical vehicle, the cream, the ointment, the gel, the spray, the liquid, etc. So, and what really defines the difference between these is the amount of water and the amount of lipids. So when we talk about a gel has a very high concentration of water, around about 90% water and only 10% lipids. And when we think about the local anaesthetic, they are lipophilic. They like lipids and they don't like water. So we have the issue of how do we, if we have a gel formulation, is how do we get the local anaesthetic well maintained, suspended, evenly distributed throughout the product. In a cream, we'll have less water and more lipids. It's typically around about 70% water and 30% oil, and that will be in an emulsion. Again, the local anaesthetic being lipophilic. How is that distributed, maintained within the product, within the vehicle? And then increasingly important when we start to think about its clinical effect is how is that product going to be released? And when we look at an ointment, that is, it probably wouldn't be 100% oil, but it would be predominantly the oil and lipids. And here we would have a local anaesthetic, which is lipophilic in a virtually 100% lipid environment. It's going to like it, it's going to be very attached, but how is that product going to actually deliver the local anaesthetic from it? And that's where we get to the interesting bit. It's how the products are formulated. So none of the topical anaesthetics that we've seen and have discussed so far are just straight creams, gels. They're not just put together as a straight cream or a straight gel with the local anaesthetic contained within it. It has to have been considered and formulated with the view of creating a mechanism that would allow the local anaesthetic, that lipophilic local anaesthetic, to be delivered from that cream or gel and pass through the stratum corneum to the site of the nerve endings within the cutaneous layers below it. And the way that was used by Emler, who were the first to crack this conundrum, was using what's known as a eutectic mixture. And a eutectic mixture is where two ingredients are mixed together, and the result of that is the melting point of the two ingredients when they're both together is lower than they are on their own. And the reason for doing that is so that when the product gets to a level of heat, is that those active ingredients become oil droplets. They no longer become large molecules. They become much smaller and they've melted and they can form oil droplets. And this was the route that Emler took when it mixed lidocaine with prilocaine. The reason for using the two ingredients less was from the point of view of thinking I want to have two local anaesthetics present. It's that I want to create a eutectic mixture that when I combine them, they will be able to melt in form oil droplets. And that is also the principle that is followed with Pliagilis. There are two active ingredients in this case, an ester and an amide, tetracaine and lidocaine, and they are both mixed together to form a eutectic mixture. So what we're talking about here is how much of those local anaesthetics can get formed into oil droplets, and it is then in the hope that those oil droplets can penetrate through the skin. So if we look at EMLA as the example, then the melting points of the lidocaine and prilocaine ingredients in their singular states are between 40 and 60 degrees, depending on which one you're talking about. So if we apply those to the surface of the skin, it is rare that the skin will get to those temperatures. Therefore, the active ingredient won't melt. It won't be able to form oil droplets. When the two ingredients are mixed together, their melting point becomes 18 degrees C. So if we can get the product to that temperature, then actually the local anaesthetics will be able to form into oil droplets, and they then have a greater potential to penetrate through the stratum corneum through the intracellular route. So these oil droplets can then start to pass through the lipid channels between the corneocytes in the stratum corneum and start to penetrate into the dermis. At that point, then they can start to form a greater concentration, and with the concentration gradient start to diffuse down into the dermis. And it is this principle that is also followed with the prilocaine strategy with its formulation. There's an interesting twist to the formulation of the Amitop product as well, and we'll talk about this again in this context of reduced melting points. Here a eutectic mixture isn't used, but a formulation of using this lipophilic active ingredient tetracaine and get it into a metastable hydrate condition within the aqueous gel. The way they did this was, and it would allow its melting point to reduce again. So here they used another mechanism rather than a eutectic mixture, but using a single ester active tetracaine, they were able to reduce the melting point. Now this was at 30 degrees C, so it's higher than the EMLA formulations. However, this, if we remember, tetracaine is an ester, so it is highly lipophilic. So the oil globules that are formed are highly lipophilic, and we will be looking at the intracellular pathway through the lipid membranes. And the more lipophilic, then it will help the penetration. The stability of the products is also important just from a practical point of view. And it's interesting that the two tetracaine-based products that we've reviewed, their formulation stability requires the products to be refrigerated at 2 to 8 degrees C before they're dispensed. So their delivery and storage in the wholesaler and at the pharmacy will need to be refrigerated, and the delivery through the supply chain and to the clinic should also be temperature controlled. This is the case for Amitop, and it's the case for Pliagilis. This temperature restriction doesn't apply to EMLA cream or LMX4 cream. The other factor that is a consideration with the formulations we've just reviewed then is the occlusion, and the occlusion is an important part of the efficacy of the product. The occlusion will help heat the product and help retain heat within the skin over the area that the occlusion is applied. As we can see, we've reduced the melting points, but we want of the products in those formulations. But actually we do need to get the temperature up, so the occlusion will help with that. Also, the occlusion then sort of superhydrates, it keeps the water within those corneocytes within the stratum corneum. That gives us a nice compact effect, and it can help enable the passage through the intracellular route. So that's why for the eutectic mixtures or the more heat sensitive formulations, where we want to get the product melting at 18 to 30 degrees so that we can get the oil droplets formed, then occlusion can be a really important part of that. The delivery mechanisms we've talked about have referenced basically trying to reduce the melting point of the active ingredient, so they can form oil drops, and those oil drops can then penetrate through the intracellular lipids within the stratum corneum and through into the dermis and start to build a concentration gradient and diffusion into the dermis. LMX4 uses a different mechanism, but it is to help penetration through the intracellular lipids, and that is the use of liposomes. Liposomes are very small spheres made up of phospholipids. Phospholipids, as you know, I think we talked about right at the beginning, are also the building blocks of most cell membranes. A phospholipid has a hydrophilic, i.e. a water-loving head, and a lipophilic tail. And when they're formed in liposomal creams, these tiny spheres are fantastic for holding lipophilic active ingredients within these tiny little spheres, because within the spheres are all these little lipophilic tails which will hold on to the lipophilic active. And as we know, lidocaine is lipophilic, so effectively what we have within a liposomal cream like LMX4 is lots of tiny spheres that are containing the active ingredient, the lidocaine. And so in the case of LMX4, these liposomes can help deliver the lidocaine through the stratum corneum and into the epidermis, and then diffuse through into the dermis. And the phospholipids, which are making up the liposomes, are now in a natural environment where there are lots of phospholipids. So there's a high concentration of phospholipids, and in that case, they can then start to release the lidocaine at the point where it's needed, in the region of the nerve endings. And that's how the delivery mechanism of LMX4 works and differs from the other products. So the final part of this presentation is to consider the role of the topical anaesthetics in the clinical practice. Now, fundamentally, from a dermatological anaesthetic practice, we're obviously talking about cutaneous procedures, and the topical anaesthetics are indicated for cutaneous pain. But any pain that's created deeper than the papillary and reticular dermis and to an extent the hypodermis would not be indicated for treatment with topical anaesthetics. Also, if we're starting to treat areas which have greater thicknesses of the skin, so for example on the abdomen, the buttocks, etc., and we're going down into deeper areas, then one needs to think about the level of efficacy that can be expected. And then if we're treating areas which have a more cornified, thicker outer layer of the skin and outer part of the stratum corneum, for example, it can be seen on the soles of the feet or on the palms of the hands, then again then the effect of the local anaesthetic and the expectation of the efficacy of the local anaesthetic in the form of the topical anaesthetic would need to be considered. In terms of the normal procedures that are taking place, we really need to think, I guess, around cutaneous injectable procedures, and the following products that we've considered throughout this are all approved for use in terms of injectable procedures. Amla cream is approved, but with a minimum application time of 60 minutes. LMX4 cream is approved for needle procedures with a minimum application time of 30 minutes. Amitop gel is approved for needle procedures with a similar time of onset, 30 to 45 minutes. And Pliagelis cream is approved for needle procedures with a minimum application time of 30 minutes. The other major use that will be considered for topical anaesthetics in a dermatology or a medical aesthetic cosmetic practice is application to larger areas of skin prior to painful treatments on the skin. For example, skin needling, skin laser procedures, radio frequency procedures, and painful topical products such as more abrasive chemical peels. When we look at the products that we've reviewed, then the following products are approved for application to larger areas of the skin and will be consistent with this use. That's Amla cream, for which the minimum application time is 60 minutes. LMX4 cream, for which the minimum application time would be 30 to 60 minutes, and Pliagelis cream, where the minimum application time is 30 to 60 minutes also, depending on the depth of the procedure, the depth and the level of pain associated with the procedure. That concludes this presentation on using topical anaesthetics for anaesthesia of the skin. I'd like to thank you for listening. I hope you have found it of benefit. My details are on this slide. If there's a need for, if you have any further questions, would like to get in contact with me, my email is detailed there. Thank you very much.